Hi, everyone. Welcome back. I think we'll hopefully getting everyone together in the next few seconds. Okay, we'll just get back to our presentation and I'll just quickly help us get back on track. So we hope that you are able to share your thoughts. I'm hoping that we will be able to second. Gosh, you work with one screen. Right. So we've basically got an opportunity for you to give us some feedback. I hope that you've been able to get onto menti.com and use that code at the top to give us some feedback. We're not going to wait for you, but we'd like you to put that in. We'll come back and have a look at what your results look like. So for those who can remember, basically indicate there, just go to menti.com or Menti on your Apple or Google App Store and download Menti and just add in the code at the top there, and then you'll get these questions. So we're going to go through these questions and I'll just mention them very briefly, and then we'll kind of just have a little bit of feedback from the people that are from groups. So while we are going through this, you can add your own thoughts on it if you feel you'd like to share. So these are the things that we'll come back and have a look at what you put on there, whether it says something different. So these are the questions we've basically asked you to discuss. So let's just talk to some of the groups and see what the feedback turned out to be. So perhaps we can start with any group that's willing to provide some feedback. I think I remember Joy, Maria, Mercy as being facilitators. If you can point out the person who is perhaps giving feedback, or if you are giving feedback, and we really encourage anybody who's got feedback. So if you could pick up your hand, and I'll just give you, I think, co-hosting. If you need to share, you can also do that. But I think just some quick verbal feedback. I think let's start with Maria, and then Mercy, then Joy.
Charge here some acidic water. Let me wash my hands.
Right. I'll just ask people to keep themselves muted, and just for now, just stop you unmuting yourself. And then if you're going to give feedback, please pick up your hand and then I can unmute you. It'll be much better. Great. Carry on, Maria.
Okay, thank you very much, Subi. We were a group of 10 people. We come from different countries, me, Spain and Zimbabwe, Zambia, Kenya, Cameroon, very active, nurse, midwife, pediatrician, educator, nurse. And we went to the 3 questions. What are priority areas for the improvement of patient safety in your health centers? We were talking about the empowerment of healthcare providers, enhancing teamwork for multi-professional teams, investment in resources for primary care facilities, improving mainly is infrastructure, buildings, beds, other facilities, water supplies, PPI for patient safety. Then we talk about human resources for primary care to develop skills to enhance the quality of the training of the healthcare professional of different disciplines, and to increase the number of professionals who provide the healthcare. We consider as well the community awareness and partnership and involvement in their own healthcare, doing some kind of health literacy to improve patient safety. Shabi, do you want I go on with the 3 questions, or do you prefer to get the 3 answers from the group for the first question? I do not know. Well, I go on. We talk about the barriers that make it difficult to work safely in your health center. The main barriers were inadequate funding. That was the biggest barrier. No resources, electrical shortages, no PPI, lack of investment in primary health care facilities. We were concerned because hospitals received more funding than primary care facilities. We were worried about some community situations because there were some primary care teams working in very deprived areas, which will need more resources than those working in rich areas. At the same time, we talk about staff shortage, essentially primary care doctors. And sometimes that when we are overwhelmed with work, we are in stressful situations that may lead to decreased patient safety good practices. We consider as well that there are some religious and cultural beliefs may compromise patient safety for patients and the communities. And another barrier was the political issues. Political instability may lead to difficulties to implement patient safety culture. At the same time, war issues in the community, it's a threat for patient safety. We consider another barrier, the lack of regulations and law to facilitate health professionals to speak up about patient safety issues safely for healthcare professionals. And finally, some economic challenge which threaten patient life due to lack of diagnostic tests or medication because of economic constraints of the patients. And regarding good patient safety practice, we consider that before COVID-19, we were talking about central hospital quality assurance policies and in primary healthcare as well. In some regions, they have developed standard operating procedures for each department that will guide practice and standard healthcare for patients to reduce the likelihood of harming patients. Another good practice would be to raise awareness of the community, to empowering them with some new skills, advocating all leaders and all members in the community to improve the patient journey as safe as possible. Then we develop in the group explain some infection control programs to improve the quality of care in hospitals and primary care facilities. To promote quality assurance meetings, we were talking about different types of meetings, perinatal review meetings, whole hospital meetings with the executive board regarding quality issues, and as well patient complaints assessment to develop healthcare improvements in the facilities. And finally, we talk about that sometimes the referral system among primary care and specialized or hospital care is a big barrier because sometimes it compromises the life of the patients, the lack of a proper information report regarding the patient, or some referral delays for other specialties or for hospital care may seriously compromise patient health and may cause very severe adverse events. And that's all from group 1. I do not know if some member of the group may add something that I have forget, but please do it freely.
No, thank you very much for that notes and I think that comprehensive feedback. Appreciate that, Maria. If you don't mind, just you can email it to me or stick it on the WhatsApp on the chat as well. That'd be really good. I think we would really appreciate keeping these and integrating it into our documents. Maybe Joy, then Mercy, sorry. Joy and then Mercy, and then I think the other groups, if you can also pick up your hand, that'd be really helpful. Go ahead, Joy.
Thank you. Our group had a rapporteur who took the notes. That's Sharon, and
Sharon.
I will give her the opportunity to speak.
All right, Sharon Kubai, is it? Okay. Sharon, I'll
Yes,
just give
from
you the
South
ability. Okay, thanks, Sharon. So Sharon, you can give us some, and anybody else who's sort of giving some feedback or would like to give us some feedback, please pick up your hand and I can allow you to speak. Go ahead, Sharon.
Thank you, Chairperson, for giving me this opportunity. In our group, we had representatives from Cameroon, Kenya, Uganda, and South Africa.
Nice.
So for the priority areas which need improvement, on our discussion, we discussed about capacity building, training and retraining of health professionals, which will help. Number two, we also indicated that the trained health professionals need to be employed. Proper recruitment of skilled professionals can assist. And then number three, we also discussed about implementation of quality assurance programs, where it was indicated that the clinical audits should be aimed.
So carry on, Sharon. I'm not sure where that's coming from, but carry on. I'll just double check, but I don't think anyone else is able to speak. Go ahead, Sharon.
We also discussed about implementation of quality assurance programs, which it was discussed that clinical audits should be aimed at improving quality patients' care, not to punish health professionals. And then it was also discussed that for the health professionals for the health facilities to be effective, finances are needed. It was also discussed that in some other countries, you find that we do have diversity where language can be a barrier. And then it was also discussed that in some other health facilities, we also find that a nurse-patient ratio is inappropriate due to overcrowding, and then this could compromise the quality patient care. So I think that was all that was discussed.
Nice.
So any member of the group can add on what I have already indicated or presented.
No, thank you. Anyone who would like to add? I think Al-Mughira, you have your hand up. Were you in the group, Al-Mughira? All right.
Yes, he was. I think Sudan
Yes.
was missed out.
Okay, Al-Mughira, you can go ahead. Yes.
Thank you for this opportunity. And I think unintentionally Sudan was missed from mentioning.
Okay. I know. We'll get a pick up on all the countries just now.
But I apologize for that because I joined the team late. I think as it is mentioned, one of the things also the governance. Beside the healthcare financing, which is very low, especially for the primary healthcare, we have to stress this point. Healthcare financing, I think one of the big problems that stand behind many problems regarding the health system in general and primary healthcare in particular. So the primary healthcare is really, it's very obvious in our continent is underfunded. This is one. The other thing is the governance. I think unless there is, because also in the group we mentioned that the Ministry of Health in Africa, usually the Ministries of Health, usually it is a provider itself. It is a provider and it is a judge for this provision of healthcare services. So how comes you are the provider and you mention the quality of this healthcare? True. So unless there is a separate or a separate entity that monitor quality and judge the Ministry of Healthcare provision, we will not move forward. And I also convey some of the steps in Sudan that is we started, but still we need more strengthening of it, which is a provider purchaser split. As the Ministry of Health is a provider, health insurance was within the Ministry of Health, but one of the interventions that it was separated from the Ministry of Health and being affiliated to the Ministry of Social Development. So this makes like health insurance is the purchaser, and the Ministry of Health is the main provider.
Yeah.
So you can here make I can buy this, I can put my standards for quality, for the safety of patient, in order to have this facility receiving insured patients. I think one of the steps that can promote or improve the quality of healthcare services as well as patient safety in our continent. Thank you, and sorry for being long.
No, thanks. I think very important point, the financing and particularly strategic purchasing as a way to, excuse me, to build quality. Thanks, Samuira, for that. I think we've got some comments from Roland and then Paul. Go ahead, Roland, let me unmute you. Roland, you should be able to unmute. Let me just...
All right. Greetings to everyone.
Good. Karen.
All right. Yeah, thank you very much. I am Acha Roland Achi from Cameroon. I was a rapporteur, or I took notes for Group 3, or Room 3.
Right, good.
So I'll just present what we had as...
Good. Wonderful.
Okay, for our first question, the priority areas for improving patient safety in our health centers, what we got was the first thing was the human resource. Priority should be human resources, the quantity and quality. That means we should improve on the capacity, the training, the quality of training, especially in service training, and then motivation of the human resource. And then we equally try to increase the number such that we reduce workload and stress. So human resource, quality and quantity. Now the second was standard procedures and protocols. We equally consider that it would be better if protocols and procedures are harmonized in all the institutions, because in some areas, the procedures and protocols are not harmonized. Some institutions do different procedures, while others are equally doing something different. At times might be difficult, and it might pose a risk to the patients. Then the next point we talked on was proper waste management in terms of the training, the tools, and the equipment that are used, that are to be used for proper and efficient hospital waste management. Because at times some of these elements, when they are lacking, we might have aspects of nosocomial infections and other risks that the patient might have in the course of treatment within the hospital facility. We equally talked on a priority area, which is data management and improvement, especially on the aspect of data capture and data utility. Most of our services don't have the appropriate tools and equipment that will enable us to collect all the data that we need to have for patients and patient information and other aspects. And at times we don't even use the data to inform our decisions. So at times it might be difficult for us to make appropriate decisions and changes that will require us to push forward or to improve on our quality, because either we don't have the data or we are not even using it. Then the last aspect under that was patient education and involvement. At times we equally have noticed that in our settings, patients are just cut off. It's like the health providers just are contented with themselves. They provide care. They don't educate the patient on what the patient is supposed to do. They don't educate the patient on why the treatment is being given, and they don't actually teach or educate the patient on his or her own responsibility to ensure safety and efficacy of the treatment. So at times the patient, in their ignorance, do some things that actually end up being harmful to them in the course of their treatment. So we think prioritizing patient education and involving them too in treatment is a priority area for safety. Now, going on to the second question, what are the barriers of patient safety? What our group noted, Group 3, was first, poor information flow and poor documentation. We saw that at times our systems don't have enough and easy to document documents, and at times when it comes to transferring from one unit to another, or from one service to another, it becomes difficult because either the information get lost or the informations are not properly transmitted on time. And so there is some delay in information that can be used for patient care. We equally talked about the aspect of cultural and religious factors. We saw that most of some of our African countries, especially in the context of Cameroon, we have a diversity of ethnicities and culture, which have different elements and different ways in which they view some health procedures and some health protocols like blood transfusion, some nutritional aspects. So at times it's difficult when you are giving health education or you wish to undertake a procedure. There are some cultures that don't even want surgery, per se. So at times it's so difficult to bring the patients and the family to understand that some of the procedures that are being taken, that we wish we carry out, is actually for their safety, because their religion or their culture might not permit that, and they may be hesitant, or they may reject. We equally have the problem of lack of mutual respect and collaboration among health personnel themselves. At times, the health facility is made up of a multitude, or is multidisciplinary. We have nurses, we have doctors, we have specialists, and different categories. At times, there is this kind of conflicts and fighting or poor coordination between them. If it is a doctor, it is different. If it is a nurse or a midwife, they see themselves, there's this kind of an war, or let me just say poor collaboration or conflict. Sorry that at times it acts into the detriment of the patient, because there's lack of team spirit and poor maybe collaboration and communication. So the patient ends up suffering.
True.
They will have poor capacity building. Some of the nurses or the health personnel don't have facilities or possibility of undergoing continuous in-service training. So at times, after a very long period of time, they get incapacitated because new technology and new procedures and new research, protocols and information is coming up, and some of them don't have that possibility or the opportunity to learn and inculcate them or integrate them in current practice. So some of them most of us at times are lost because with time, we are not abreast with the current trends of events and procedures. Then for the third aspect, which was good practices, what are the good practices? Anyway, time cut us short, but the thing we emphasized on was proper documentation and collaboration with colleagues. And then we should enforce the use of standard operation procedures so that it could be easier and for people for nurses or health providers to respect procedures and to do it on time with little possibilities of making mistakes. If it is well documented and is well provided, it will limit the time and possibilities of thinking on your own or trying to critically think, and so you will not waste time and you will not make mistakes. So basically, that's what we had for our group, room 3. And so I leave the floor open for those members of the group who could add something more. Thank you very much.
No, thank you very much, Roland. Wonderful stuff. And I think your point is human resource number and capacity and capability and capacity, I think, development. So I think great. Sharon, can I ask, you've already presented, I think, eh? So I'm going to just mute you. Let's go to Paul and then Mercy. I don't know if there are any other groups. I think we've had 5 groups so far with the 2 left that will come forward. And then we'll just get some closing comments from our panelists, and then we'll close. But thank you. Those are wonderful shares. And if anybody has comments, please add them in the chat so that we can get everybody's views. Anything you feel missed, any point that you feel you need to add, please feel free. Right. Paul, I'll let you unmute. And then group 2, Francoise, is that yourself, or do you want to just tell the person who is going to present to just pick up their hand? I think if the person from group 2, is it Francoise yourself or somebody else?
Okay. This is Paul.
All right, go ahead, Paul.
Yes. I actually from Sierra Leone. I think the group 2. I was in group 2, and Sierra Leone was never mentioned. I raised 2 very important issues with regards the patient safety net. I said it's good to engage our policy makers to actually domesticate the National Action Plan on patient safety nets, to have policy that can criminalize violators. You know, I shared my experience here in Sierra Leone. That I work on the TB side. We have a lot of discrimination, a lot of stigma that is going around tuberculosis, TB patients. You know, but there is no policy, there is no act to protect them. So I think it's good to have generally TB, HIV, and all of this. To have a push on policy, then also to have a national awareness raising, especially targeting the primary health workers, care workers, and as well as community. So these are two very important things that I think should be part of a way forward. You know, knowledge sharing, raise awareness, and also policy that can protect the right of patients from discrimination, from stigmatization, from rejection, you know, so that it can be more protective in terms of the patient. So these are the two things I wanted to mention: policy and awareness raising.
No, great stuff. Thank you, Paul. Appreciate that. We'll go to Francoise Mercy, and then Francoise will also present on the group. Thanks. Go ahead, Mercy, and then Francoise. And Francoise will include a comments as well, closing comments. Ahead,
hello,
Mercy.
everyone, and thank you. So I'm not going to repeat most of the points that have already been mentioned by other rooms because they are mostly the same. So what I'm going to just highlight that was a bit different or that stood out was one, when it comes to the barriers of patient safety, there was a lot of emphasis on patient involvement, patient-centered care, and also transparency. We don't talk to our patient, we don't tell them everything, we do not tell them the truth. And when it comes to the practices that help to foster patient safety in the various facilities that we could borrow from, one that I liked very much, I think, was the issue of emphasizing on IPC. Like one facility mentioned how for them hand washing is key and it's very important, and they really emphasize on that. And second, especially in the COVID in the COVID era, is the use of masks. They emphasize that all patients, as they're moving around the hospital, you're not allowed to move within the hospital without a mask, which I think is very important. And another practice which I found very key was patient feedback. One facility gets feedback from patient, whether written or verbal, before they leave the facility, asking them if there's something that went wrong, if something could have been done better, if they were treated well with the staff, if all their needs were taken care of. Then after that, they address those needs that were mentioned. Yeah, so I think those are the only things that from our group that was different from what has been presented. And if any other member would like to mention anything that I may have forgotten that's important, they can go ahead. Thank you.
Thank you very much, Mercy. I think that was really nice sum up of the issues. And any comments, please add them to the comments section. We're running a little bit out of time, so please use the chat to add anything that Mercy might have missed out. So thanks, Mercy. And Francoise, would you mind giving us the last, I think, group, is it? Wonderful, Francoise. Francoise, are you able to unmute? Okay, sorry about that, Francoise. Make your co-host so you can unmute yourself. Francoise, you should be able to speak now.
Okay.
Good.
Thank you very much. Good afternoon again, everyone. It was quite an exciting session. I will just pick some of the points that my group mentioned. I was in group 2, and there was quite an interesting discussion there. One of the points is about medication prescription. Talked about the tendency to always overprescribe, which is not healthy for the patient. We also spoke about communication. The feedback, the kind of communication we give to the patients is not adequate for them. We also mentioned interprofessional collaboration. That's for question 1. There's no good interprofessional collaboration between the different members of the team and the standard operating procedures. They've mentioned that. We also spoke about evaluating the competencies of the health workforce as we move along, and look for gaps and see where to build capacity in different areas. We also spoke about the lack of materials and equipment at the PHC level. No matter the will and the health workforce, we need these materials in order to function properly. Those were some of the points that came up that I don't want to repeat some of the points that others have mentioned. As for question 2, we spoke about the organization being better organized ourselves. We spoke about the absence of regulation. We spoke about no or proper or lack of proper continuing education, which we keep the health workforce confident about what they are doing, and the support system is not there, and the task sharing is not adequate. Sometimes we don't know who does what and when and how, and so it causes some problem. We also have the outreach equipments are not there, and some of these patients walk quite a very, very long distance, more than 30 minutes, to get to a health center. And when they get there, some of the care, some of the problems they've come with is not being attended to in that health center. So it was one of the problems that was mentioned. And for question 3, what are the good patient safety practices? We spoke about the political will. Yes, we also spoke about the participation of the community. PHC, according to the definition, it should also be self-reliant in a spirit of self-determination. The community also should be determined to make it work. We spoke about accessibility. We spoke about availability. Sometimes we don't even have these health services. People have to walk very many kilometers to get to a health center. We spoke about affordability. We spoke about the updating our practice in the whole sector, in whether in the east, in the north, in the south. We should be practicing the same thing. We should have the same procedure. Everybody should be doing the same thing. And so those were some of the key points that came up. Thank you very much.
Thank you. And Francois, don't go away. We'll just quickly. I think that you've also brought up lots of very important issues. A lot of the sort of contextual challenges we have as healthcare workers. Perhaps what's your closing remark? You know, sitting back and looking at this this meeting today, you've contributed. Any closing remarks, and then we'll move to our panelists and close with them as well. But or maybe I'll come back to you. Let me do that. I'll come back to you, Francoise, as the last remark. Let's turn to our guests. I think perhaps with Maria and Nikhil, you know, you've had a chance in this meeting, workshop, to be able to engage with a whole lot of people and hear the sort of African story. Any thoughts about that? Thanks, Francois. I'm going to come back to you with the last remark. Maria?
Okay, thank you, Sabir. Well,
I think it's been very full.
Thank you very much for giving me the opportunity to share the vision. I think primary care have quite the same problem in different levels, but most of the same problem, the lack of resources in other parts of the world. One of the main issues is the lack of human resources and the lack of investment. And well, the basic level is different. Some are in European countries where we can have more facilities and more possibilities, but regarding or comparing to hospitals, we have big differences, and we have to raise awareness for politicians that primary care is the foundation of the health system. I think the universal health coverage will help a lot to deploy the primary health care system and to strengthen primary care, because nevertheless we have more facilities in developed countries or in countries with more structured primary healthcare systems, the economic constraints regarding the patients are already there. We were talking in the Wonka working party about Latin problems in USA regarding the economic constraints to afford healthcare. During COVID times, most of the government raise awareness on this condition, and they provide COVID testing free of charge, and they provide vaccination free of charge. But nevertheless, diagnostics tests and transportation to other healthcare facilities are really a problem. And other thing that you have already mentioned as well is regulations and laws to move to being able to speak up about patient safety issues freely in order to introduce those analyses into the quality improvement plans of the organizations. Means I think we can share our main analysis to the health organization, because if we do not share this analysis, organizations are not going to change, so they are not going to learn and improve. And this is an issue. Frontline workers will have to perform properly. Thank you, Xavier.
Thank you very much. I think, you say globally, the same challenge, is global, which is primary care versus the hospital and the emphasis on hospital. And I think that's true for all of us, but Africa has got its challenges in terms of much less resources. And I think that we have to find our ways to use what we've got to push and advocate as AfroPHC, to push for improved quality ultimately. And I think even when we talk to human resources, we've got to say it's about delivering good quality, which is really what you as a politician and a voter want. And I think that we've got to speak to them rather than just complain about ourselves. But I think that, in some ways, we are coming together, and it's quite a diverse group of people. And I'm going to put out the poll again. I'm going to relaunch it so we just see, what is the spread of people in the meeting. So please feel free to add your details, where you're from in Africa and what your professional background is. In the meanwhile, Nikhil, I hope you're with us still and that you're able to just share. Nikhil, is it Nikhil Prakash, eh?
Nikhil, so whenever I don't change the name, it shows the default name. I don't know, some funny. It's my middle name, Prakash.
No problem. So Nikhil, if you don't mind just sharing your thoughts. I mean, you've had the opportunity also to engage in sort of close discussion with providers. Your closing remarks.
So thank you so much to include me in one of the group also. And I was listening carefully. For some time, I was out of the room because, there was a call from my teammate from WHO. But I was doing a multitasking. From earphone, I was listening the discussion, and from my phone, I was listening to the call. So
thank you.
So even when I was listening, it was giving me a nostalgia. I won't give much kind of a global perspective. I've been to WHO for now 3.5 years here at the headquarters, but most of my career has been in a same kind of a setting, what we are discussing here. And the constraints were same. And I would say somehow we can say that resources, because of the kind of availability of resources and non-availability, some of the challenges may be different, but still these remain, what Maria was also saying, it remains irrespective of the resources. Somehow I would say when you have less resources, it gives you sometime more push and space to do innovation, do some disruption, do some out-of-box thinking, some frugal thing that you may not even think of when you have a lot of resources. And one of the resources, what I think is most important, sometimes we don't go into that much of depth, is the time of the physician or the nurse itself. And my exposure to primary health at very much local level is that the doctor is or the nurse is so much kind of overrun by the administrative procedure. So they don't get too much of time to devote to the patient care or to the clinical work, or they have so many forms and register to fill and everything. If WHO has produced this series of safety in primary healthcare, and one of them is about administrative errors only. So when we have too much of repetitive work, and some of them can be made more streamlined, there are chances of errors, and that happens. And primary care is very much important because we have very, very niche commodity. I won't say commodity is not a very good word, but we have just a doctor or a nurse that is doing everything. So we have to think about from where he or she will get time for maximum time for, so we can second, from kind of when we're talking about, because about what interventions should be done to improve in patient safety in primary care, specifically in Africa, what we received as a part of the second or third question. We got almost all the suggestions when we were even sitting in a global kind of a consultation. You get all about accreditation, about resources, about medication safety, about everything. What I would suggest is, if we can pick one or two specific intervention, rather than just creating a la carte of all the interventions, we can list them. But when we are going to execute, let's take maybe just polypharmacy or the medication safety and the prescription practices as an intervention. I'm just suggesting one of them. We can take as per the, you know better. Very good that suggestion. Will give more focus and will give some kind of a early feedback to us also that something is happening. Sometime when you spread out too thin into a lot of things. My experience is that we don't get anything and we are engaged in everything. So that could be one good thing. We made a list from here, what group discussion that what could be done. If we can prioritize 2 or 3 for next 1 or 2 years, and then see how that works, how we do quality improvement, otherwise plan to check it. So that could be a good approach. Thank you so much again for giving me this opportunity and listening. This is always the best experience, listening from the frontline care providers, what's happening there. That's the most happening place, more than headquarters in Geneva.
Absolutely. I mean, that's what I find really fun. And I always, resent the fact that I can't be part of that. I have to try and make sure the technical stuff works. But the really exciting stuff is when people are sitting in these groups and they share. And these are people who are sitting, and just probably left a patient and coming and telling you things. And I think that's really where I think, anybody who's worth their salt ought to be listening to those people. So really great stuff. And I think that, like you said, we need to, we've got a sense of, we've got a really wide group with lots of people from very many different countries, very interested in this issue. So we need, and we've gathered some information, which we'll try and collate. And I think this will become some of the information we will include in documents that we will try and prepare, that we will present to, stakeholders as this is the path to go forward. And I think one of those elements is to build evidence around it and try small things out. And I think your suggestion is spot on. Small things, especially even in quality improvements, small, few indicators, and even as a research project, I think it's something that we can all explore and take forward. So thank you very much for your presentations and your spending time with us. And we really don't mind that you went off for a little bit. Really, the fact that you sat to the end is really very, very appreciated. I think perhaps we could get Joy and then Francois to make some closing remarks. We're almost at the hour, and I think we'll close. And I think I'll just give some idea quickly that we will be providing the presentations. I think you don't mind just sharing it with me by email, and I'll put it up on the webpage together with the recordings of this meeting up to now. Perhaps some closing remarks, Joy, and then Francoise.
Thank you very much, Prof. Shabir, and thanks to our speakers for such a fantastic session. Not only to the speakers, but also to the attendees, everyone from each and every African country. I have learned quite a lot. And for me, I take home the fact that quality and patient safety challenges are not an African or a Kenyan situation. They are a global problem, but we have the solution. We can work with our patients and we can share our solutions as an African region and be able to ensure that we have the best outcomes for our patients. So with that, I say thank you very much and look forward to hearing more from the team.
Wonderful. Thanks, Joy, for facilitating. Francoise?
Yeah, thank you very much. For those that joined late, I'm Francoise Mwabuko, the Vice President of AfroPHC. It's quite interesting to have you all here, and we started timidly, but it really ended up interestingly. I've learned a lot from all your sharings and experiences that you shared with us today. And one thing we are taking again here is that we have a lot of challenges, especially concerning the health workforce, but it should push us into innovating and getting better organized so that we can do with what we have. Because if we keep complaining, it will take quite a long time to increase. But what do we do with what we have? We organize ourselves better, innovate different strategies of how to use what we have at hand. And so for those that are joining for the first time, on behalf of AfroPHC, we have workshops, we have research, we have trainings that goes on here, especially every 2 weeks, every monthly. And we started a session with Professor Shabi. He's really doing a lot in this platform with the PhD students, and it is quite interesting. There's a lot on our website. I would just pray that a lot of you should visit our website and really study some of the things that are there, especially for those that are still students. There's a lot of material for you. And why not become a part of AfroPHC? There's a lot of training. There's training on management, which is free of charge. So thank you all for attending today. We will want to have you again here next time. Thank you very much. Prof,
thank you all. Thank you very much. And I think just to echo Francoise, I think the capacity building is us already. We're doing capacity building by bringing us all together and helping each of us to understand each other. And to me, that is an important capacity we need. This is probably the first time some of us in different countries are talking and focusing on primary care with different cadres in primary care. And I think that in itself is a major leap forward, and we need to understand each other, become more closer and more one. And I think we would be able to then take these forward with all these great suggestions and great ideas that have come forward. So with that, thank you all very much. Appreciate it. Like Francois says, please join the AfroPHC. The website is on the group. Just Google AfroPHC and you'll be able to join us. Lots of stuff there. We'll see you next time in a month. And we're going to be having a collaboration with Wonga Rural to talk about rural issues in primary health care and African primary care. So see you then. Bye-bye. Take care.
Thank you very much, Sabi. Thank you. A pleasure.
Thank you to all our speakers.
Thank
analysts.
you.
Bye-bye.